evolving images in radiology. We are talking about medical images, and then the first one years ago, that is 9th November 1895, Wilhelm Conrad Röntgen, a German physicist who has been a Nobel Prize winner also. He has discovered, while experimenting with some tubes, new rays, and he called them as X-rays. Since then, many advances have taken place. For example, during centenary year between 1895 and 1995, we have described the various evolutions that have occurred in radiology and imaging. 1920 to 40, it was the introduction at various places simultaneously in Europe, America, even in India. They have tried experimenting with the new rays called the X-rays. In 1940 to 60, the growth of X-rays, namely the contrast media, the Bucky diaphragm, the protection, the radiobiology, all these changes have taken place between 1940 and 60. And then 1960 and 80, proliferation of new imaging methods, ultrasonography, radionuclide study, and then CT. These are the angiography, contrast media, radiopaque other substances that have come during 1960 and 80, and 1980 afterwards, many more changes have taken place. Really evolutionary changes, which are revolutionary in their nature. In the sense, the resolution of the images is great, almost to histological diagnosis we can make, particularly with MRI, and recently PET scan also has been introduced. You remember early on, when we had the X-rays with us, we took plain films of the skull. For everything in the brain, whether it is seizures, headache, whatever it is, still we took plain films. And we took advantage of the calcifications in the brain. That's how we said maybe it is a tumor or maybe it's a hemorrhage, but that was a guess. Later on, because we couldn't visualize the ventricles where the CSF flows, we added air ventriculogram, putting burr holes and then injecting air. And then later on, pneumoencephalogram, injecting air into the subarachnoid space of the lumbar canal. We visualized the various ventricles, the fourth ventricle, the third ventricle, the aqueductus, and also the lateral ventricles. And then this is the pneumoencephalogram where there is marked hydrocephalus with air fluid levels that we can see. And then came the contrast ventriculogram. With the iodinated contrast, we found out the ventriculogram is much better defined rather than the pneumoencephalogram or air ventriculogram. And there, if there is any defect, we could find out. And then came Egas Moniz, 1927. He was the president of Portugal also. And then first cerebral angiogram, he made it with a thoratrast contrast medium. But unfortunately, we couldn't continue with thoratrast because it's radioactive and may produce hemangioendothelium of the liver, spleen, etc. And then in 1972, the revolutionary changes have taken place in computed axial tomography. That's where, for example, this is the three-dimensional view. You could see the fracture of the skull, whether it's entering into the sinuses, into the orbit, and extending into the sphenoid also. And in CT, we could find the hemorrhage, either due to trauma or due to hypertension. Wherever the hemorrhage is, we could locate. And also, we could differentiate various tumors. For example, this is a case of multiple meningiomata with calcifications. And then we came across with the vessels, study of the vessels, aneurysm of the anterior communicating artery, nicely seen in three-dimensional picture, and also the basilar artery aneurysm. And then there is a real debate whether when you are studying the cerebral vessels, is MRI better or multi-slice CT or high-resolution CT is better. But then the disadvantages of CT is, of course, radiation. And also, in certain cases, you have to inject contrast media. Both are not well recommended. Whereas in MRI has come, and then early ischemia, aneurysms. For example, look at the MR venogram, the entire sagittal sinus as well as the transverse sinus and all the venous system you could easily study. Because in ischemia, it is not only the arterial system, but at times venous infarcts are also seen. And then the more beneficial part is MR neurospectroscopy. Here, by studying the choline content or the lipid content, you can easily differentiate between a granuloma and a brain tumor, infarctions from infections, neoplasms and degenerative diseases or multiple sclerosis. We can easily differentiate, although it is not 100% specific, but it is really contributory to the differentiation between the various tumors. And then in utero ultrasonogram, you could see the hydrocephalus, markedly dilated ventricles, and then the encephaloceles, various anomalies, not only the skeletal, cardiac, chest anomalies you can easily study in utero of the fetus. And then latest is in imaging modalities, PET scan, positron emission tomography. It is actually useful in ischemia of the heart, in studying the coronary artery disorders. It is more sensitive than the regular angiogram. And also you can localize the various epileptogenic foci. And also you can differentiate between recurrence and radiation effect. For example, this particular patient had temporal lobe epilepsy, and you can identify the focus. Even from head to toe, some of these images, whether it is CT, MRI or ultrasound, in every part of the body you can visualize it easily. For example, look at the orbit, normal anatomy beautifully. Even on dissection, you cannot really depict the normal anatomy, namely the lens, the oblique muscles, the optic nerve, etc. And also differentiate between normal and abnormal. For example, this particular picture is the Coats disease, where you can easily identify the pathology in the orbit. And then remember, we used to do myelogram by doing a lumbar puncture and injecting contrast media. Even the contrast media had adverse effects in those days, and of course it has been painful to the patient. Instead, today we are doing, without any pain to the patient, the MR myelogram. For example, in the conventional myelogram, you could see the changes produced by the disc compression effect on the myoidal column. Similarly, in discogenic disease, we used to directly inject contrast medium into the disc and differentiate which is a degenerated disc, which is a herniated disc, which is a sequestrated disc. Today, fortunately, we have got MRI, and MR myelography is not painful to the patient. You can take in any direction you like to. For example, look at this case. There is a cervical disc at C6, C7, and you could see the defect over the contrast material. And then, not only this, the spinal angiography with AV fistula, AV malformations, you could easily identify, and then the interventional radiologist embolizes this. That's how they treat it. And also the interventional radiologist, whenever there is a carotid stenosis threatening to produce strokes, you can introduce a stent. Earlier, in conventional angiography, we used to inject by Selding's method from the femoral root or from the axillary root. Actually, from the femoral root, we used to pass the catheter up to the aortic arch and look at the vessels, cephalic vessels. Today, fortunately, we don't have to do that. With MRI, you could nicely see the vessels, and the occlusive disease also you can easily identify. And then in the lumbar spine, all congenital anomalies, acquired anomalies, dislocations, fractures, contusions, transverse myelitis, and this particular example, for example, in a child, newborn child with neurological abnormality, the so-called diastematomyelia, that is the splitting of the cord into two, either by a bone spur or for a cartilage or even a fibrous band could split the cord and produce symptoms. And in those days, olden days, we used to have conventional tomography, the so-called linear tomography, a lot of radiation to the patient. And this is, for example, one of those cases where we have to identify whether a certain small nodule is calcific, is it well defined, or is there a cavitation. You could, in those days, identify by linear tomography. But today, fortunately, we have got cross-sectional tomography. Cross-sectional tomography, cross-sectional studies, you can also do in ultrasound, in nuclear scan, in CT, in MRI, in PET scan also. In the principle of identifying whether it is a solid structure, whether it is a bone, calcium, fat, in other words, tissue differentiation you can make by present day computer tomography. A pleural nodule, we have taken a PA and a lateral views. This pleural small nodule could not be identified unless you take a cross-sectional tomography. Also, normally the water gives a 0. That is, we measure these densities in terms of Hounsfield units. The man who has discovered the CT, we name the terms as Hounsfield units. Water is 0 and fat and air are minus, and calcium, cartilage and bone are plus. It can go up to 3000 plus or 1000 minus. Similarly, high resolution CT, you can find out small lesions, you can find out beautifully the air bronchograms in this consolidation. You can diagnose emphysema better, the airway disease, and also the pulmonary artery hypertension, and in fact you can trace the vessels all the way to the third or fourth branch. And in congenital disorders, for example, this is an example of agenesis of the right lung with a multi-slice CT. A virtual bronchoscopy can also be done today, whether this is a stenosis or a polyp or an ulceration. Virtual bronchoscopy, as if you are doing the actual bronchoscopy and identifying, except the added advantage in actual bronchoscopy is you can take a biopsy. Whereas here, in virtual bronchoscopy, you can demonstrate a lesion, but you cannot take a biopsy. In this particular case, partial agenesis of the right lung, look at the atretic right bronchus. Look at the nice bronchus on the left side with its branches, whereas the atretic right bronchus, you could identify the bronchial lumen and also shift of the heart and mediastinum to the right. Then in 1940s, angiocardiography has come first. Otherwise, you could not visualize the chambers. On regular PA view of the heart, all you could see is the silhouette of the heart. Whether it's the right atrium or left atrium, right ventricle or left ventricle, you couldn't differentiate unless you injected the contrast medium. Those were the days. In this particular case, for example, by angiocardiography, you could identify the diffuse aneurysm and also the adjacent clot of the descending aortic aneurysm. And today, for example, you come across a PA view of the chest. Is it a mediastinal mass? Is it solid, cystic, or is it a heart chamber? Is it aorta? Simply by looking at the CT, cross-sectional anatomy, you could definitely say that it is a dissecting aortic aneurysm. For example, you could see the lumen of the aorta and also the blood clot surrounding the periphery of the actual aortic lumen. And then ultrasound, pericardial effusions. We used to do an inspiration and expiration film and also do fluoroscopy for the pulsations in those days. But today, with ultrasonography, you can identify with echocardiography, you can identify the various chambers, the pericardial solid structures, pericardial liquid structures such as effusion. Similarly, with radioisotope scan, you can identify the muscular wall of the left ventricle or right ventricle and find out whether the blood is supplied to that, is it viable or not viable by these studies. And then, fortunately for us, Seldinger, 1953, has developed the Seldinger needle and a technique, and by femoral route, we can easily pass a catheter wherever we want and study, for example, the coronary arteries. This is one of those coronary angiogram. It is the standard, gold standard today, coronary angiogram. Whatever methodology you use, for example, CT, MRI, any other methodology, but ultimately gold standard is coronary arteriography and angiography. And then contrast media, you can visualize the various bronchi. For example, this is a particular case of bronchiectasis. Today, of course, with CT, you don't have to use contrast media, which has got its own adverse effects on the patient. And then we'll come to the mammography. Since breast cancer is increasing even in India, we have to do some routine mammography in some of the high-risk patients. For example, you can differentiate a benign adenoma, well circumscribed, whereas in a malignancy it is irregular, speculated, and sometimes shows microcalcifications. Even in mammography, there are various techniques: ultrasonography, CT, MRI, etc. And then in 1910, for the first time, contrast medium, which is safe. Earlier they used to use metallic substances which are injurious to the patient, whereas barium sulfate has been proved to be quite safe, and in 1910 they have discovered this barium suspension, and since then, even today, with slight modifications in the liquid, we are using barium suspensions in studying the entire gastrointestinal tract. With the advent of endoscopy, of course, the number of studies in the gastrointestinal tract or the number of studies in the barium enema of the colon have reduced, but still occasionally we use this. For example, look at this case, the deformed duodenal bulb, which is indicative of a chronic duodenal ulcer. And then small bowel is more or less a blind study even today for the endoscopist. Although some people are doing by small bowel enteroscopy or the capsule study latest, but still the conventional radiograms are not so good because it is the barium floods the small bowel. So enteroclysis, passing a tube and studying segment by segment of the small bowel, has become the routine study today. And then they look at the, by MR evaluation also, we can study the mucosal surface of the small bowel, intraluminal filling defects, longitudinal studies, as well as motility and function of the small bowel. And not only we are satisfied with the contrast studies, but we use double contrast studies, namely either barium suspension or oil suspension and with air contrast, so that the barium coats the mucosa nicely and the air distends the lumen. That's how you could see a nice pedunculated polyp. And if the head of the polyp is more than 2 centimeters, then we know it is undergoing malignant changes. Similarly, a villous adenoma of the rectum with it is simulated to a sponge soaked in barium. That is a mottled type of appearance is characteristic of a villous tumor. And in children, intussusception, acute abdominal colic, you can study, not only study and identify whether it is ileocolic or ileoileal or colocolic. Not only that, you can even reduce by using some regulated pressure the intussusception by fluoroscopy and barium enema. And today, of course, the ultrasonography also tells us, without introduction of barium or making the child cry because of the introduction of barium, with ultrasound you can identify the so-called bullseye appearance of the intussusception. And then endosonography, the lumen of the esophagus or the stomach, you could identify and study, and then you can actually display the various layers of the esophagus, where is mucosal, submucosal, muscularis, and then see the staging of the esophageal cancer, or when once it is treated with radiation therapy or even surgical anastomosis, recurrence also could be studied with endosonography. You remember the studies of the gallbladder, we used to do oral cholecystography today the present student even doesn't understand what is oral cholecystography because it's not done anymore. In those days, we used to take different views, and in the erect posture, look at that translucent band. Those are the floating cholesterol stones. Of course, if they are calcific, even the plain film can show it. And today, that is more or less replaced by the ultrasonography, and you can identify the single stone, you can study the gallbladder wall, you can study the pericolic collections also. And then came the percutaneous transhepatic colonography. Provided the bile ducts are dilated, you pass a needle through the liver, inject contrast medium, and study the biliary tract and study where the stenosis is, or if there is malignancy, or if there are stones, if there is obstruction, you can easily study. For example, in this particular case, look at the stricture of the common bile duct. Postoperative cholecystectomy was done. And whereas in the second picture, you study the distended gallbladder with multiple stones. Look at the various filling defects. Distended common duct, because there is a carcinoma in the head of the pancreas, occluding the common duct. And then came the ERCP. It is mostly done, why mostly? Always done by the endoscopist. But then the cooperation of the radiologist is necessary to take appropriate films in various positions to demonstrate the pathology. That's why I define or redefine ERCP into endoscopist, radiologist, cooperative performance instead of purely by the endoscopist. Look at the extrinsic pressure by lymph nodes over the common duct in this particular film. And then CT. What is the role of CT in pancreatitis, in biliary tree? You could easily identify the pancreatitis, the various stages of acute pancreatitis, the phlegmon, the abscess, the necrosis, everything you can identify by the cross-sectional tomography. And then the pseudosis also, although ultrasonography demonstrates this pseudosis, but still small pseudosis which may be obscured by the distended gas by ultrasonography can be identified with this CT. And then the biliary scan by the radioisotopes, you can identify the liver, the gallbladder, the common duct, and also the flowing, normal flowing of the bile into the duodenum. This is the IDA scan. And then hemorrhages, say either hematemesis or melena, is a big problem. Where do you identify? You can't use contrast medium. The endoscopy with a flooded blood, you cannot do endoscopy. In those cases, we do angiography so that to identify a bleeding ulcer, either in the stomach or in the duodenum, or a bleeding polyp in the small bowel, you can diverticular bleeding, you can easily study by the angiography. Again, passing the catheter to the femoral root and studying the superior mesenteric, inferior mesenteric, and gastroduodenal vessels. This is the hemorrhage in the duodenal area because of the ulceration in the duodenum, acute bleeding ulcer. And the next film is the CT, contrast CT. You can identify the pancreas and the phlegmon of the pancreas, diffuse broadening of the pancreas due to the necrotic tissue. And then the IDA scan and the PTC, ERCP can be replaced without any damage to the patient, that is any trouble to the patient, by the magnetic resonance cholangiopancreatography. The resolution may not be that great, but still you can identify the gallbladder, the hepatic bile duct, the common bile duct, and including the pancreatic duct. Ultrasonography, today, particularly in India, ultrasonography is playing a major role because it is cheaper, simpler. Anybody with 6 months or 1 year training can easily study ultrasonographic films. And then not only that, there is no contrast absolutely necessary. It doesn't hurt the patient. That's why ultrasonography is highly beneficial to the Indian patients. And then there are several modifications in the technology: high spatial resolution, harmonic imaging, endosonography I told you earlier, and then tissue enhancing contrast, and of course power Doppler to study the circulation, the velocity of the circulation, the speed of the circulation, the lumen of the vessel, whether it is narrowed or dilated. This is a film of the abdominal nodes in a case of lymphoma, where with ultrasonography you can identify the nodes. And then 3D ultrasound in a fetus. You can study the anomalies. For example, look at the cleft lip. Look at the nose, the upper lip, the lower lip, cleft lip and the upper lip. You can easily identify with 3D ultrasound. And then ultrasound also is useful in the gynecology. Papillary cystadenocarcinoma of the ovary, which is the papillary portion, which is the cystic portion, whether it is a solid ovarian cancer, you can easily identify. And then in the fetus, omphalocele, various other abnormalities you can easily identify. Years ago, we used to do contrast medium, inject into the cervix and body of the uterus to study the various anomalies, not only the anomalies, disorders like polyps, and in this particular case, you could see the uterine synechia. And then today, with ultrasound also, it can be studied, but the resolution is not that great. So, histography is occasionally used today, and most of the time we use hysterosonography also. And then carcinoma of the cervix, the CT, the staging, and the distended uterus with blood clots, you can easily study. Adenomyosis, fibroids, carcinoma of the uterus, you can study by the ultrasound. And ectopic gestation by the ultrasonography you can easily study. And as I told you, 3D imaging in ultrasound is of great value, particularly in the fetal anomalies. When coming to the urinary tract, and although IVP studies we used to do, ultrasonography we can do, but still occasionally CT scan is useful. For example, as I told you earlier, you can measure the tissue, various differentiation of the tissues, whether it is soft tissue, necrotic tissue, bone, cartilage, fat, air, with the Hounsfield units. Look at the right kidney. There is no doubt there is a tumor, but what kind of tumor? Is it a carcinoma? But if you measure those contents, it is fat. So if there is fat, and with contrast if there are vessels, it must be an angiomyolipoma in a case of tuberous sclerosis. Carcinoma of the bladder, you don't have to do cystoscopy, and you can stage also by the CT, the thickening of the bladder, the irregularity of the bladder. Is it polypoidal mass? Is it diffusely infiltrating mass that is involving the prostate, rectum? All these you can easily study by the CT. And in this particular second case, you could see MRI of the bladder. It doesn't hurt the patient. You don't have to inject any contrast medium. A huge lobulated sarcoma, rhabdomyosarcoma at the base of the bladder involving the prostate. And then the hypertension, particularly in the kidneys, periarteritis nodosa. Look at the small multiple aneurysms of the intrarenal arteries. There is no other method except doing an angiography and studying these various aneurysms. Similarly, in fibromuscular dysplasia, more common in females, you could study the various types of, is it intimal dysplasia, is it adventitious dysplasia, are there aneurysms? You can easily study by the conventional angiography. Of course, Doppler studies also will help, but the resolution here is much better. If a patient where there is no, or where there is a contraindication for contrast media, you can easily identify by Doppler sonography. And then MRI, what is the role of MRI in urography? You can do MR urography. Look at the first case. You can see the irregularity at the base of the bladder due to carcinoma infiltrating the lower end of the ureter and thus producing the hydroureteronephrosis. And here also you get marked hydronephrosis, marked distended pelvis, ureter, calyces, due to obstruction by a small tumor, a transitional cell carcinoma in the ureter. And then coming to the musculoskeletal system, still conventional radiography plays a major role, particularly in tumors, fractures, dislocations. Ultrasound may also help in studying early fractures. And then spiral CT, radionuclide study, very important in studying the metabolic status of the skeleton or metastasis. And then MRI, of course, particularly in joints, the cartilages, the fibrocartilages, the hyaline cartilages, the ligaments, all this could be easily studied by MRI. This is a radionuclide study. The film on the left side shows multiple hotspots wherever there is metabolic activity, either due to, say, endocrinal factors, or due to osteoporosis, or due to fractures, or due to metastases. Hot activity will be there. By correlating the history, or by studying the pattern of distribution of these hotspots, you can easily tell whether it's metastasis or a diffuse metabolic disease. Similarly, for example, one on the right side is a Paget disease, selective hotspots in the right iliac bone and also in the vertebrae. There are some blind areas for conventional radiography. For example, a lesion in the sternum. If you take a PE or APV of the chest, it is obscured by the heart vertebral column. If you take a lateral, it doesn't give you a real picture. In those cases, the CT is extensively useful. For example, plasmacytoma of the sternum, you can see the lesion, the surrounding soft tissues, how far it is extended. Similarly, in tuberculosis of the spine, if you take a conventional view, you cannot really assess the perivertebral tissues. Is there a calcification? Is there a psoas abscess? And then this particular case shows calcific debris in the periphery of the vertebral body, indicating tuberculosis of the spine in a healing fashion. And then MRI, actually MRI is more sensitive in depicting marrow lesions than, I should say, isotope scan. We have seen several times where isotope scan is not that sensitive as compared with MR study. Osteonecrosis of the femoral heads, which is a common feature in youngsters or oldsters, whether iatrogenic or otherwise. We have seen few cases where, although we used to teach that isotopic study, bone scan is highly sensitive, but today we know that it's not so highly sensitive as compared with MR studies. Ladies and gentlemen, the importance is not just imaging, not just the anatomical study, not just the physiological study, but interventional radiology has become part of imaging studies. We can remove the fluids, FNAC, core biopsy, embolization and bleeding, or in tumor therapy, infusion studies, dilatation if there is a stenosis, or stenting as you have seen in the carotid artery stenosis. So imaging is for detection, characterization, and also interventional therapy. Now, digital radiography, where it is precisely much more, you can easily study the fractures or even the chest, the lung structure by digital radiography. And then with digital radiography, you don't have to use films. In various parts of the country, we have filmless departments. And then picture archiving. If you are in one place, say a neurosurgeon wants to see the films by himself instead of going all the way. Of course, today there are no films, but he can, on his computer, he can study the various images in his own room and then communicate to the radiologist. Although the high tech is very costly for us, but still we are catching up with high tech, and initially there are some inhibitions. Oh, it's too costly. MRI is too costly. We can't afford it. But then it's not the affordability. It is what is helping the patient in alleviating this suffering, and what is helping the patient in early diagnosis So we have to get used to the high tech, although it is a little costly. And then today it is an era of genetic analysis, gene therapy. In this era, the imaging methods by gene delivery, they are very important, of course, although it is in research study, but still one has to look into the future for gene deliveries. Recently only, Lauterbur and Peter Mansfield, they got the Nobel Prize in medicine for the discovery of MRI, magnetic resonance imaging. Ladies and gentlemen, the evolution of the images is like the evolution of revolution of the transport. Remember the bullock cart? From there, we are using the jet. This is the jet age. Like that, the future is great. For you youngsters, you study the past, ignore some of the bad effects of the past. For example, you don't have to have the radiation hazards today. Without radiation, you can use the MRI, ultrasound. Similarly, in future, we look forward for a better imaging, better resolution, cheaper, and the quality should be much better.